Today our first speaker is Kieron Dunleavy. He graduated from the University College of Dublin Medical School in 1994. He completed his residency and fellowship training at Mater and St. James Hospitals in Dublin. He came to NCI in 2002 and became a staff clinician in 2006. He's in the Lymphoid Malignancies branch, and the title of his talk is Lymphomas. Kieron.
Okay, hi Terry. Thanks for the introduction. So my name is Kieron Dunleavy, and I'm the clinical director of the Lymphoid Malignancies branch at the National Cancer Institute. And over the next 45 minutes or so, I'm going to talk about lymphomas. The first half of the talk is some general principles about the biology and treatment of lymphomas, and then I'm going to talk about some of the research that we have been doing in our branch, just to give you some sense of the translational work that we can do in lymphoid malignancies here at the NCI. So in terms of how common lymphomas are compared to other cancers in the US, in males, they're the 5th most common cancer type, and in females, they're the 6th most common cancer type. But the incidence of lymphoma is increasing, and there are a lot of reasons for that. First reason is probably because there is an increase in the elderly population. So as with really all cancers, as people get older, they have a higher chance of developing cancer, and that's true for lymphomas, particularly for certain subtypes of lymphomas. Also, certain diseases are associated with lymphomas. HIV is associated with it. If you're HIV positive, you've got about 100 times increased chance of getting the most common type of lymphoma, which is called diffuse large B-cell lymphoma, and about 1,000 times more increased chance of getting Burkitt lymphoma, which is a pretty rare lymphoma, but it's often EBV-driven and strongly associated with HIV. And when we talk about lymphomas, there are Hodgkin lymphoma and non-Hodgkin's lymphomas. And as you can see, non-Hodgkin's lymphomas are much more common. They make up 83% of all lymphomas, and Hodgkin lymphoma makes up 17%. So in the US, I'll focus on non-Hodgkin lymphoma a lot during this lecture. There are 75,000 cases of non-Hodgkin lymphoma per year. And as I said, the incidence rises with age, and that's the biggest reason why we're seeing an increased incidence of lymphomas. And shown here are SEER data showing you the period from 1992 to 2010 and the incidence of NHL in both males and females. As you can see, there has been an increase in the incidence of NHL in both males and females during that period of time. But the good news is that there has been a reduction in death rate from lymphoma during that same period of time in both males and females, as you can see from these curves. So for most people who develop lymphoma, there is no known etiologic factor, but there are certain factors that put you at increased risk of developing lymphoma. So people who've got altered immunity have got an increased risk of lymphoma. Some of the examples of that are diseases where you have inherited altered immunity, like Wiskott-Aldrich syndrome. As I said, acquired altered immunity. Patients who have HIV have got a much increased risk of developing lymphoma. People who have iatrogenic altered immunity, such as people who have undergone a cardiac transplant or renal transplant or bone marrow transplant and they're on immunosuppressive drugs, these patients have an increased risk of developing lymphomas, and they have a particular type of lymphoma called PTLD, or post-transplant lymphoproliferative disorder. And people who have had certain types of chemotherapy are also at increased risk of developing lymphoma. At the NIH, we have a group who study Sjogren's syndrome. And interestingly, when we do blind biopsies of these patients, you could do blind lip biopsies, and you find that almost all of these patients have got evidence of mucosal associated lymphomas when you look for it. So autoimmune stimulation is an increased risk for lymphoma. Acquired immune stimulation is Helicobacter pylori is an organism which you can get in the stomach, and there are certain lymphomas in the stomach that are associated with this. And actually, in some cases, if you eradicate the organism, if you eradicate Helicobacter pylori, you can see regression of the lymphoma. That's not in most cases, but it's in some cases. And hepatitis C and HIV are also examples of this. Our understanding of the link between chemical exposure and lymphoma is not very well established, but it would appear that certain chemicals like organic solvents, agriculture chemicals, and maybe others are associated with lymphoma. There's a lot of interest at the moment in the microbiome and microbial oncology, and while we've certainly identified some organisms that are definitely linked to lymphoma, I think that there are a lot of other infections that possibly cause lymphoma, but this has not been definitively established at this point in time. So of the infectious etiologies that have been associated with various lymphomas, Burkitt lymphoma, as I said, is a rare lymphoma. You see three different types of this. You see endemic Burkitt lymphoma in regions of the world like equatorial Africa. It usually occurs in children between the ages of 3 and 5. And this type of lymphoma, it often presents with jaw masses, and it is linked to EBV in 100% of cases. The other two types of Burkitt lymphoma are sporadic Burkitt lymphoma, which is the type that we see most commonly in the US, and then HIV-associated Burkitt lymphoma. And both sporadic and HIV-associated Burkitt lymphoma are EBV positive in about 40% of cases. Hodgkin lymphoma can be linked to EBV, and post-transplant lymphoproliferative disorder, particularly after kidney transplants and heart transplants, can be linked to EBV. Obviously, AIDS-related NHL is linked to HIV. There's an unusual leukemia lymphoma called adult T-cell leukemia lymphoma, which is caused by the HTLV1 virus. And this, again, is seen in distinct regions of the world, particularly the Caribbean. And these patients develop ATLL, which is a very aggressive lymphoma and is largely incurable. And most of the therapies that we use for other lymphomas don't work for this type of lymphoma. Primary effusion lymphoma is seen almost exclusively in patients who have HIV, and it is linked to the HHV8 virus, as is multiple myeloma. Lymphoplasmacytic lymphoma is linked to hepatitis C. I talked about MALT, linked to Helicobacter pylori. And Mediterranean lymphoma is linked to an intestinal pathogen. So the most important thing, when a patient has lymphoma, has newly diagnosed lymphoma, the most important thing is the pathology and getting the pathology right. And really, the tissue needs to be looked at by a pathologist who's really expert in hematopathology and in looking at lymphomas and has seen lots and lots of these lymphomas before, because they're becoming, or they are, a very complicated group of diseases. So I think it's best if the person making the diagnosis is not a general pathologist who looks at all different types of cancers, but really focuses on lymphomas and hematological diseases. And for all cancers, there's a WHO manual, which is very helpful in making the diagnosis for pathologists, and it really lists all the different types of lymphomas and their different characteristics under the microscope, and also clinically how they present. And we're certainly in an era now where a lot of lymphomas should not only be diagnosed by how they look under the microscope, but also how the patient presents. So this is called a clinico-pathologic diagnosis. So when we have a new patient with lymphoma and we look at their biopsy with our pathologists, they always like to know about how old is this patient, what did they present with, what did their CT scan look like. So it's important for them to know that, because that helps in both establishing the diagnosis, and in doing that, they can request special tests on the tissue that will be guided by the clinical presentation. And then lymphomas are classified according to whether they're T cell or B cell. About 85% of lymphomas are B cell, 15% are T cell. Their location in the lymph node, the appearance of the cells, molecular features, specific genetic abnormalities, and clinical features, what the history was coming in and what disease sites the patient has. And if you look at the breakdown of non-Hodgkin lymphoma, the most common type by far is diffuse large B-cell lymphoma. That makes up about 40 or 45%, followed by follicular lymphoma. And after that, there are a number of different types, but they're really pretty rare, as you can see here. So for the most part, when we have lymphoma patients, they have diffuse large B-cell lymphoma or follicular lymphoma. As shown here is the lymph node, and depending on where in the lymph node the lymphoma arises from, it can be very, very different. For example, you can have marginal zone lymphomas, which arise in the marginal zone, and follicular lymphomas, which obviously arise in follicles. So this is important for the diagnosis. And most lymphomas are B-cell lymphomas, and you can correspond B-cell lymphomas to different stages of B-cell differentiation. So precursor B lymphoblastic lymphoma is, you can correspond that to very early B cells, CLL a little bit later, and then the main lymphomas that we see a little bit later. And I'll talk a little bit about this in relation to diffuse large B-cell lymphoma, because that's the most common, the common histology. And when the pathologist is looking at a new lymphoma under the microscope, they use immunohistochemistry to decide what type of lymphoma it is. The lymphoma has a particular appearance in terms of its morphology with H&E, but immunohistochemistry is very helpful. And this was something that really wasn't around 20 years ago. So, for example, if it looks like a diffuse large B-cell lymphoma, you would do CD20, BCL6, MUM1, CD10, and all of these stains will be very helpful in telling you that that is the definitive diagnosis. And likewise, there are T-cell markers, which can tell you it's a T-cell lymphoma. So immunohistochemistry is very important. Cytogenetics are done in certain cases. For a lot of B-cell lymphomas, follicular lymphoma and diffuse large B-cell lymphoma, they frequently have a 14-18 translocation, leading to overexpression of BCL2. So that's found in close to 100% of follicular lymphomas and in about a third of diffuse large B-cell lymphomas. The lymphomas that are associated with Helicobacter, a lot of those can have an 11-18 translocation. So if the pathologist is told this lymphoma is coming from the stomach, that's something that they might do to confirm that it's a MALT or mucosal associated lymphoid tissue lymphoma. And Burkitt lymphoma has a MYC rearrangement, so that's an 8-14 translocation. That's present in 100% of Burkitt lymphomas. So Burkitt lymphoma is a very easy lymphoma to diagnose under the microscope. It's got a particular what's called a starry sky appearance because of the high proliferation of the tumor cells. But if you check for a MYC rearrangement, it's positive in 100% of cases. There's an unusual type of T-cell lymphoma called anaplastic large cell lymphoma, and that's got a 2-5 rearrangement. So the pathologist really decides to do these tests based on their suspicion or where they're going with the diagnosis. They're not done on every single lymphoma. It's really guided by how it looks under the microscope. So then when you have a patient with newly diagnosed lymphoma, how do you evaluate them? The first thing is you ask them what has been going on with them, what have they presented with. The most common presentation in lymphoma is having lymphadenopathy, and people usually notice this in areas where you can feel your lymph nodes. So they notice it in their neck, under their arms, in their groins. If you have lymph nodes in your abdomen, it really takes a long time before you notice them. So most of our patients, when we ask them, what have you been complaining of? They usually say, I noticed a lump in my neck or under my arm or in my groin. And these are usually caused by infection, but when these are caused by lymphoma, they usually don't go away with antibiotics, obviously, and they're also usually non-tender. Infectious lumps tend to be tender, whereas most patients who present with lymphoma, if they have a lump, they'll tell you that it doesn't hurt at all and it isn't really causing me any discomfort or any distress. In the history, we ask specific questions about how people have been, obviously, but there are symptoms called B symptoms, and those are fevers, night sweats, weight loss of more than 10%. And those are important because they put patients into different prognostic categories. So depending on the lymphoma type you come in with, if you have B symptoms, that might indicate that you have a more aggressive lymphoma and it's associated with a worse prognosis than if you don't have B symptoms. Everybody who comes in, you should examine them, obviously. That's very important. And then do blood tests. All of the basic tests should be done. There's a test called lactate dehydrogenase, which is a liver enzyme, but it's a non-specific test of tumor bulk. And that's often elevated in aggressive lymphoma. So that's a test that patients should have done. Once all the and everybody who presents with lymphoma, they should have a HIV test done because of the association with HIV, and they should also have hepatitis screening done. They should have hepatitis screening done for two reasons. One being that hepatitis can be associated with lymphomas, and two, certain types of hepatitis can reactivate with chemotherapy and with rituximab, which is a drug that nowadays we give to all patients with B-cell lymphomas. Everybody should have imaging of their chest, abdomen, and pelvis, and that's called staging. And there are 4 different stages: stage 1, 2, 3, and 4. And stage 1 or 2 disease means that the disease is on one side of the diaphragm, and if it's 3 or 4, it's on both sides of the diaphragm. And that's really becoming less important. 20 years ago was important because if people had very early stage disease, they typically got chemotherapy, but then they got radiation treatment if it was in one particular location. But nowadays, radiation is used less and less frequently. So staging may be becoming less important. Almost all patients should have a bone marrow aspirate biopsy done. In the B-cell lymphomas, the most common ones, in follicular lymphoma, the bone marrow is involved in a very high percentage of cases, probably about 15 to 20% of cases of diffuse large B-cell lymphoma. And then other studies should be done as indicated. There's a lot of work in looking at the role of FDG PET scans in the initial diagnosis of lymphoma, so a lot of doctors will do these. And then depending on where the lymphoma presents, for example, if you have a lymphoma in your brain, it's best to do an MRI scan. And certain types of lymphomas and certain presentations should have their spinal fluid checked. So if you have aggressive B-cell lymphoma and if you have involvement of what are called extranodal sites, sites that are outside the lymph nodes, or if you have involvement of the bones, or if you have a very high LDH level, there are certain criteria that suggest that it's really important to check the CSF, because the treatment that we give to patients, it doesn't really get into the central nervous system. It doesn't, for the most part, penetrate the blood-brain barrier. So you really want to know if a patient has involvement of the spinal fluid. It's rare to have it, but it's associated with certain clinical factors. So if a patient has those, then we would recommend that you check the CSF. And it's fine to interrupt me at any point if you have any questions, but just, or we can ask. I'm happy to answer questions at the end. This is the staging system that I told you about. I won't go into it too much, but there are 4 different stages, and 1 being just one lymph node area, and 4 being diffuse or disseminated involvement and involvement of extranodal sites. And as I said, the morphology of lymphoma is important. This is diffuse large B-cell lymphoma morphology. And typically, you see large cells. They're about twice the normal size of a lymphocyte. They have vesicular nuclei, prominent nucleoli, and are basophilic, and they're large cleaved or multilobated cells, and they may be rich in T lymphocytes. So over recent years, there's been a huge amount of interest in the tumor microenvironment. It might be something that some of you are focusing on, but it's really important in certain types of lymphoma. So not just the tumor cells, but the infiltrating immune cells around the tumor cells. And in follicular lymphoma and diffuse large B-cell lymphoma, if you look closely at what these infiltrating cells are and what their genetic expression is, you can predict how certain patients will do. So the tumor microenvironment is becoming very important in lymphomas, and we're starting to develop therapies that actually target the microenvironment, not just the tumor cells, but also the microenvironment. Okay, so what about the outcome of patients with lymphoma? How do they do? Are most of them cured? And for this talk, I'll focus on diffuse large B-cell lymphoma quite a bit, because that's the most common type and the type that you see the most when you look after patients with lymphoma. So these are Kaplan-Meier curves, and they show on top overall survival and progression-free survival on the bottom. And you can see here that the interval is in months. So this is out to 100 months, which is quite a long time. And these are patients who, of all ages, who had diffuse large B-cell lymphoma, and they received the standard treatment, which is a chemotherapy regimen called CHOP, which is cyclophosphamide, H is hydroxydonorubicin or doxorubicin, O is oncovin, which is the trade name for vincristine, and P is prednisone, which is a steroid. So, and R is rituximab. And over the past 20 or 25 years, the most significant advancement in treating patients with DLBCL has been the addition of rituximab to CHOP chemotherapy. That has increased the cure rate by about 10 to 15%. So it's very important to give rituximab. And it's interesting because the adult world and the pediatric world in lymphoma are very separate. And the pediatric world has been very hesitant to give rituximab, and they really haven't been giving it to everybody up until a few months ago, where they were doing a big randomized study in children, and they were randomized to get rituximab or not to get rituximab, but they have recently shown a little bit earlier than they expected that there was a significant survival advantage to giving rituximab. So now everybody, adult and child, who has diffuse large B-cell lymphoma gets rituximab. But I think what these curves tell you, I mean, if you're a new patient with DLBCL, and these are, patients can be divided into low risk IPI, intermediate risk, or intermediate high risk IPI. It's called the International Prognostic Index, and it looks at your age, the stage of disease that you have, whether you have an elevated LDH, your ECOG performance status. So if somebody's really fit, it's 0. If somebody's not really fit and lying in bed, it's 2 to 3. And then the presence of extranodal sites. And that's what the low risk, intermediate risk, and high risk is. But these curves just tell you that with standard treatment, so all around the world, if you go into an oncologist with diffuse large B-cell lymphoma, you get R-CHOP. But you can see that for a significant proportion of patients, standard therapy is not adequate. So, you know, while most people have a long overall survival, a lot of people don't, and a lot of people progress, as you can see from the curve on the bottom. So our field has really been trying to improve the cure rate for DLBCL, and a lot of different strategies have been tried. What have people been doing? You know, they have said, well, we usually give 6 cycles of R-CHOP, so let's try giving 8 cycles, see how that works, and that has not been helpful. It's associated with more toxicity, but no increased benefit. They've tried therapy intensification. So R-CHOP is typically given every 21 days. So people have tried giving it every 14 days. In Germany, about 10 years ago, there were some studies that suggested that if you gave it more intensely, it was associated with a better outcome. But about a year ago, a group in France and a group in the UK did large studies of patients where they gave half the patients R-CHOP every 21 days and half the patients R-CHOP every 14 days. And there was no difference in both studies. And the patients who got it every 14 days actually had more toxicity. So that wasn't helpful. People have tried doing bone marrow transplants when patients go into remission. That's not been of any benefit. But they've tried giving maintenance rituximab. That's where people finish their rituximab and CHOP treatment, and then they continue to receive rituximab for 18 months or 2 years after that. And studies have, again, half the patients have had maintenance rituximab, half had not, and there was no difference between the two groups. What are promising strategies? Well, are there better chemotherapy platforms than R-CHOP? The French developed a regimen called RACVBP, and in young patients who have a low IPI score, that was better than R-CHOP. But that was a very small proportion of patients who get DLBCL. Our group has been doing a lot of work with dose-adjusted EPOCH-R, and we're awaiting the results of a randomized study. We have a lot of novel agents that are based on the identification of new pathways in different types of lymphomas, and I'll talk about those a little bit, but I think that probably offers the most promise for improving cure rate, is to incorporate some of these effective novel agents into upfront standard regimens like R-CHOP. But as in our field, it's really critical to develop novel agents and approaches in the context of the biologic subtypes and factors. So in that respect, historically, we always thought that DLBCL was one disease, that it was just one entity. And this is work that was done by the Lymphoma and Leukemia Molecular Profiling Project. It's a big project that involves a lot of institutions around the US and Canada. And it was led actually by Lou Stout's lab, which is based at NCI. And about 20 years ago, they applied gene expression profiling to cases of lymphoma. And so they looked at the differential expression of tens of thousands of genes in a large sample of DLBCL cases. And when they did this, they were able to break down most of DLBCL cases into molecular subtypes. So most of them fell into one of two molecular subtypes, a germinal center B-cell-like type, or GCB type, and an activated B-cell-like type, or ABC type. A small percentage of them fell into another type, which I'll talk about at the end of the lecture, called primary mediastinal B-cell lymphoma. So this is a subtype of DLBCL, but if you look at its genetic makeup, it actually has a lot more in common with Hodgkin lymphoma. It shares about a third of its genes with that, and so it's really very distinct from the ABC or the GCB subtype. And so, you may ask, well, this is very nice. It's very nice to be able to genetically divide this disease into at least 3 diseases, 2 of them that are shown here. But is that helpful for patients? Does that make any difference clinically? And it does make a difference clinically. So this is a study that was published last year from a group in British Columbia. They looked at the outcome of over 300 cases of DLBCL. So shown here is progression-free survival and time in years. And you can see that this group of patients have been followed for a very long time. And they did something called a Lymph2CX assay. So conventional gene expression profiling is expensive. And this assay has been validated with gene expression profiling. It looks at the expression of about 20 genes, and there's close to 100% concordance with conventional gene expression profiling. But the advantage is this is easy to do and much less expensive. But as you can see from here, patients who had the ABC subtype had a much worse outcome than the GCB subtype. And just to go back to this, the GCB, ABC, and PMBL, all subtypes of DLBCL, but they're really distinct diseases, and they have distinct mechanisms of oncogenic activation. So the GCB subtype comes from a germinal center centroblast, the ABC subtype from a plasmablast that's blocked during plasmacytic differentiation. And PMBL is a totally different disease that comes from a thymic B cell. So it arises in the mediastinum. And if you look at the oncogenic characteristics of these three subtypes, they're very distinct. For example, GCB, which makes up the majority, you often see a translocation of BCL2. In the ABC subtype, there's constitutive activation of the NF-kappa B pathway, and that has led to the identification of many interesting targets that are currently being pursued in clinical trials. And PMBL has got activation of Janus kinase pathways. There's a lot of interest at the moment in oncology with immune checkpoint inhibitors, and immuno-oncology is a huge area. And this is a disease, there's an early study of about 20 patients, but it responds very well to immune checkpoint inhibitors. So PD-1 and PD-L1 are very important in PMBL. So just talk a little bit about the biology of different subtypes of DLBCL. So the most common subtype is the GCB subtype. So if you look at children and young adults who get DLBCL, they almost always have the GCB subtype. And the ABC subtype starts creeping in when people get older. So if you look at people over the age of 40, about 5 or 10% of them have the ABC subtype. If you look over 60, it jumps up to about 20 or 30%. If you look over 80, it's over 50%. So the GCB is the type that you see in both young and older people, but in pretty much all young people. And about 10% of those have got a MYC rearrangement. And I think it's interesting to think about that in the context of whether the lymphoma is GCB or ABC. So this is diffuse large B-cell lymphoma in general, but about 10% of cases have got a MYC rearrangement, but these are almost always of GCB origin. Whereas cases that have high MYC expression but do not have a rearrangement are almost always of ABC origin. About a third of cases have got a BCL2 rearrangement. Again, these are almost always of GCB origin, whereas cases that have got high BCL2 expression but without a BCL2 rearrangement are almost always of ABC origin. So in our field, one of the most controversial areas are the double hit and double expressor lymphomas. You hear a lot about those, and when patients call us and they want to come to the clinic and they're asking about what the best therapy is, they talk about double hit and double expressor lymphomas a lot. And double hit lymphomas are those that have both a MYC rearrangement and a BCL2 rearrangement. And then double expressor lymphomas have got high BCL2 expression and high MYC expression. But this distinction between double hit and double expressor lymphomas is really important in our field in relation to the cell of origin, GCB or ABC, because it's starting to help us decide what therapy patients should get. It's really important then to distinguish the double hit lymphomas from the double expressor lymphomas that do not have any hits, because pretty much all the double expressor lymphomas that do not have any hits are of ABC origin, and almost all the double hit lymphomas are of GCB origin. So we're starting to think more and more of DLBCL in the context of cell of origin and in the context of these rearrangements, because they make up a high proportion of new cases. So the ABC subtype is associated with a worse outcome. So there's a lot of interest in that, because we really need to augment the cure rate of ABC lymphoma. And the key characteristic of this subtype is that there's activation of the NF-kappa B pathway. So these are NF-kappa B target genes, and you can see that ABC is on the left, GCB on the right, and there's a lot more red on the left. So the NF-kappa B target genes are much more highly activated in ABC-DLBCL than they are in GCB-DLBCL. So NF-kappa B is highly overexpressed, and therefore it's a potential target in ABC-DLBCL. And over the past 10 or 15 years, a lot of work has been done in understanding the mechanisms of NF-kappa B activation in the ABC subtype of DLBCL. So for about 15 years, we've known that about 10% of patients have got a CARD11 mutation. But recently, over the last 4 or 5 years, it's been identified that about 20% of patients who have ABC-DLBCL have got a mutation in CD79A and B in the B cell receptor. And about 30% of patients have got a mutation in MyD88. And both overactivation of the B cell receptor and overactivation of MyD88 can activate NF-kappa B. So these are very important pathways in thinking about what drugs should one use to target ABC lymphoma. And we now have a lot of inhibitors of various components of this pathway or these pathways. I could probably put up about 20 to 30 drugs that are in clinical trials or in development that specifically inhibit. They're small molecule inhibitors that inhibit various components of this pathway. I'm not going to talk about all of those, but I'm going to talk about inhibiting BTK or Bruton's tyrosine kinase. So it's a key enzymatic step in the activation of NF-kappa B in tumors that have got chronic active B cell receptor signaling. So it really makes sense to think about inhibiting that. And you've probably heard about Ibrutinib. It's a BTK inhibitor. There now are a lot of other BTK inhibitors. This was really the first one. And it covalently binds to the BTK active site. And this is a study that we were involved in, but the hypothesis was that, so in ABC-DLBCL, the BTK is a critical enzymatic step in a proportion of tumors to activate NF-kappa B. So therefore, inhibiting it might be an interesting therapeutic strategy. So to preclinically confirm that this was something that might be worth doing, both ABC and GCB cell lines were treated with Ibrutinib, and different types of ABC cell lines were used. Those that were CARD11 mutated and those that were higher up than CARD11, so they didn't have a CARD11 mutant. And you would expect that with Ibrutinib that the CARD11 mutated ones would not respond to it and that GCB would not respond to it. And that's exactly what happened. So the ABC cell lines that did not have a CARD11 mutation, so they were upstream of that. They responded well to Ibrutinib. And that led to a clinical study of Ibrutinib in relapsed and refractory DLBCL. So in this study, patients had to have relapse disease. They could be ABC or GCB, and they received single-agent Ibrutinib until they had progressive disease. And as you can see from this waterfall plot, so orange is GCB and blue is ABC. Patients with ABC had a much better response. This is, those on the right had a shrinkage, those on the left had growth over 0 or below 0. But you can see that the drug is much more active in the activated B cell subtype. And in terms of responses, close to 40% of patients had a CR or a PR, and just one patient had a PR with GCB. So it wasn't very effective in GCB. So this really proved that Ibrutinib does work clinically in ABC much more than it works in GCB. This was the survival, and again, you can see that the blue is doing significantly better than the orange, and that's the ABC versus GCB. This was one patient from the study, and with single-agent Ibrutinib, you can see that they have had a very good response. One thing unique about this study was that when the results were being analyzed, a proportion of tumors had mutational analysis done to see which tumors exactly had the best response to ibrutinib. And as you might have expected, those that had a CARD11 mutation didn't respond. But the tumors with the best response were those that had both a CD79B and a MYD88 mutation. And there is now a study in newly diagnosed patients, and this study has actually been completed. Patients with the ABC subtype went onto this study, and they were randomized to get R-CHOP or R-CHOP plus ibrutinib. So we'll know in a few years' time if adding ibrutinib to the ABC subtype improves cure rate. There are a lot of other studies that are ongoing, which I haven't shown you here. One, adding lenalidomide just like this. That's an immunomodulatory agent that appears to be much more effective in the ABC than in the GCB subtype. So these studies will help us in the coming years to see if the ABC subtype is susceptible to adding one of these novel agents or small molecule inhibitors to standard regimens like R-CHOP. Just going to talk a little bit about primary CNS lymphoma when I'm talking about ABC. This is some of the work that we've been doing here. So primary CNS lymphoma, that starts in the brain for the most part. It can start in other areas of the CNS as well. And over 90% of these tumors are diffuse large B-cell lymphomas. Sometimes you can see other types. And in keeping on the ABC theme, these tumors, they resemble the ABC subtype, but they're not exactly similar, or they're not exactly the same. And broadly, you see activation of NF-kappa B. CARD11 is mutated in a significant proportion. Mutations of MYD88 are common, as are mutations of CD79B. And it's really interesting that shown here are MYD88 mutations in systemic ABC subtype, an ABC subtype called primary cutaneous lymphoma, primary testicular lymphoma, and primary CNS lymphoma. And while I think historically have thought of all of these as of ABC subtype and similar biologically, when we look at mutational status, they are very different. And you can see that over 90% of primary CNS lymphomas have got a mutation of MYD88 versus about 30% of systemic ABC lymphoma. And if you look at CD79B, it's also mutated in over 50% of primary CNS lymphomas. So most primary CNS lymphomas have got both a MYD88 and a CD79B mutation. And why is that interesting? It's interesting because what about using ibrutinib in primary CNS lymphoma? So for patients with primary CNS, although they're diffuse large B-cell lymphoma, they're treated in a very different way. And the reason for that is because the treatments we use in systemic lymphoma, like R-CHOP, they don't cross the blood-brain barrier. So for that reason, historically, this group of patients have received very different types of treatment. And they've received drugs or approaches that overcome not being able to cross the blood-brain barrier. So the two drugs that have been, or still are standard in this disease are high-dose methotrexate and cytarabine. They're actually not very effective drugs for DLBCL. We would never use them in systemic DLBCL, but they're used, they have been used a lot in this disease because they cross the blood-brain barrier. And cranial radiation has also been used a lot, and autologous transplant. But these modalities have been used because of really the failure of other agents to be effective in this particular disease. And this disease has been very challenging to institute optimal trials in. It's rare. It's difficult to biopsy patients. And a lot of these patients have got a very poor performance status, much more so than systemic ABC lymphoma. So we designed a new treatment for this disease. We took an effective regimen that is good for systemic large cell lymphoma, the EPOCH-R regimen, and we thought about it, and the drugs that did cross the blood-brain barrier, we included those. And if drugs didn't cross the blood-brain barrier, we substituted those for drugs that did. So etoposide does cross it, so we included that. Prednisone doesn't, but dexamethasone, which is also a steroid, does. Vincristine doesn't cross, but we don't really know how effective vincristine is in DLBCL and if it contributes to curability. So we left that out. Cyclophosphamide doesn't cross, but temozolomide, they're both alkylator agents, does cross and has been used in lots of brain tumors, so we included that. Doxorubicin doesn't, but Doxil, which is liposomal doxorubicin, does, so we included that, and we included rituximab. Ibrutinib, as I said, because of the high rate of MYD88 mutations and CD79B mutations, we really thought that would be a good idea in this disease, but we didn't have any information that it crossed the blood-brain barrier. Nobody had ever done studies or had ever done PK levels in the CSF to check that, so we included that as well. So we called this regimen dose-adjusted TEDIOR and combined an agent that targets B-cell receptor signaling with agents that penetrated the CNS effectively. And this is the regimen that we used. And so we gave patients 6 cycles of this. And in the very first cycle, we gave ibrutinib as a single agent for 14 days to see if it was effective in this disease, and also to do PK studies in the CSF and in the peripheral blood and assess if it was getting into the CSF and at what concentrations it was getting in, if this was effective or not. So, and what do we see? We've now treated 18 patients, but these were our first 2 patients, and we saw that it did get into the CSF for a significant amount of time and achieve meaningful CSF concentrations. The 2 top curves are plasma, ibrutinib, and its active metabolite. The 2 bottom curves are CSF, ibrutinib, and its active metabolite. And I'm not going to show you the PKs for the whole 18 patients, but this shows you that the drug gets in there at pretty good concentrations. This is over a 24-hour period. So we've treated 18 patients and have really had very good responses with the ibrutinib alone and with the dose-adjusted TEDIOR. I'll just show you 2 anecdotes from the trial. This was a patient who was 67. Back in 2010, she presented with slurred speech, nomic aphasia, gait instability. When she was worked up with various tests, an MRI showed a lesion in the left cerebellum that was biopsied. It showed diffuse large B-cell lymphoma, and she got high-dose methotrexate, had progressive disease on that, got whole brain radiation and with high-dose cytarabine, had a complete response with that, but then in 2014, she relapsed with left temporal lobe disease and also some disease outside the CNS. And actually, when she came to see us, her doctors were considering hospice at that point. So this is her MRI scan before and after she got 14 days of ibrutinib. So at the very beginning of the study, she didn't get any chemotherapy, just ibrutinib for 14 days, an MRI before and after. And you can see that this left temporal lobe lesion has regressed or significantly after ibrutinib treatment. This was another patient, again, another patient with relapsed disease who had had a lot of treatment in the past. She had a mass in the area of the brain called the corpus callosum. And again, after 14 days of ibrutinib, she had a good response. So I'm just illustrating to you that this drug works very well in primary CNS lymphoma, and we've treated 18 patients with the TEDIOR, and we have a number of patients who were very refractory to other treatments and are doing well and are remaining in remission. She's in remission now for over 2 years after this. So just to finish up, I'm going to talk about another type of mediastinal B-cell lymphoma that affects younger people, especially younger females, and this is called primary mediastinal B-cell lymphoma. So mediastinal B-cell lymphomas come from a thymic B-cell. So we all have a thymus, and in younger people, the thymic gland is much more prominent than it is in older people. And classical Hodgkin lymphoma comes from a thymic B-cell, as does primary mediastinal B-cell lymphoma. And this just shows you that there's a spectrum of these B-cell lymphomas that come from a thymic B-cell, with primary mediastinal B-cell on the right and nodular sclerosing Hodgkin on the left. And if you look at their morphology and immunohistochemistry, you can, for the most part, say that one is Hodgkin and one is PMBL, but there are diseases in between that are intermediate in terms of morphology and immunohistochemistry between the two entities. And these are called mediastinal gray zone lymphomas, and there's a lot of interest in these. I'll just quickly go through this. But the therapy of this disease has been controversial. Most patients who get this disease, they're females in their late teens, 20s, or 30s. And historically, the way that this disease has been treated is by giving chemotherapy followed by mediastinal radiation. But of course, as these patients are young females for the most part, and mediastinal radiation is a very effective treatment, but down the road, it's not a good thing. We now know from studies in children that if you get mediastinal radiation, if you get high doses of it, and if you look at patients 10, 20, 30 years later, a very high proportion of them develop cancer and ischemic heart disease. So for females, the rate of breast cancer is about 20% starting 10 years after the end of treatment. So this is a disease, because it affects younger people, predominantly females. You really want to think about that when you are selecting upfront therapy, because you might cure the patient, but you don't want them to get breast cancer in 20 years' time. I'll just quickly show you this in the interest of time. So there are a lot of different ways of treating this, but most of them include mediastinal radiation. With Wyndham Wilson, my colleague, we did a study with dose-adjusted EPOCH-R, which I've talked a little bit about, and hypothesized that if we gave that, we would not need to give mediastinal radiation, because it's a regimen that we believe is much more dose intense. It's dose adjusted, and I won't go into it again, but this disease, just like classical Hodgkin disease, they both come from a thymic B cell. They both affect young females predominantly, and they historically have been diseases that benefit from dose intensity. So we started our study and said that this treatment is going to be effective, and we don't think that patients are going to need radiation afterwards. And that would be a significant shift in how we treat this, because if you could take radiation out of the equation, that's a big deal, because then you eliminate the chance of these secondary complications like cancers, and particularly breast cancer, happening. So we treated 53 patients, and as you can see from these Kaplan-Meier curves, the event-free survival was high without radiation. It was 93%. Just 3 patients did not have complete remission with this approach, and 2 of them got radiation, and they're both doing fine. And one of them, she had a small residual mass left behind, and we actually resected it, and her disease never came back. And for our ASH meeting this year, we have updated these results, and now we've got over 90 patients. And the results are a little bit less. The EFS is about 90%, but we've shown that you can effectively treat this disease without radiation with this regimen. I'm not going to talk too much about that. I think for the last few minutes, I'll just take some questions, because I think we have about 5 minutes before the next talk. Thank you.
So where do you see the treatment going? You seem to be coming up with lots of new drugs.
Yes, I mean, I think that just like in several other cancers, the treatment is changing at a very fast rate. I would say in aggressive lymphomas, particularly in Hodgkin lymphoma, the immune checkpoint inhibitors, there are 2 that we use, one called nivolumab and one called pembrolizumab, and these really have made a huge difference, especially in Hodgkin lymphoma, but also in primary mediastinal lymphoma, which is less common. But so that's one class of agents which I think are going to change the field significantly. I've shown you some results with BTK inhibitors. I think that's throughout a lot of lymphomas and leukemias like CLL, mantle cell lymphoma, DLBCL. Certainly ibrutinib has been very effective, and now there are a lot of other BTK inhibitors. So that particular pathway, I think, and inhibitors of it are very, very effective. And then there are new transplant treatments. Some of our colleagues at NCI are doing a lot of work with something called CAR T-cell therapy, where they take T cells out of patients and they genetically modify them and then reinfuse them, and they have all different types of CAR T-cell treatments that target specific antigens on the tumor cells. So there's been a lot of work with CD19, which is expressed on B cells and in diffuse large B-cell lymphoma and in follicular lymphoma, and now they're working on other CAR T cells at present. I think they have a new study targeting CD30. So I think there are examples of some approaches that are very promising and very effective. I mean, the difficult thing about lymphoma or the B-cell lymphomas is that the cure rate is very high. So we have very effective strategies at the moment. So these new strategies are very effective, but bringing them into the upfront setting is challenging because it's not easy when, in some of these diseases, when you have cure rates of 80 and 90%, to bring these new promising agents into upfront studies. So that's the challenge. But I think that the field has changed a lot over the last few years, and I would expect will continue to change at this pace with the drug development that's happening at the moment.
Good progress.
Yeah.
What's the success rate of this?
The
Success rate of this bone marrow transplant? How many patients?
The CAR T cell treatment or the so that's still pretty new, and in lymphoma it depends on the type of lymphoma. I think the field is still trying to figure that out because I mean it's at the point of being commercialized at the moment, but up until 2 or 3 years ago, a lot of groups all around the US were really developing their own type of CAR T cell therapy. There are different vectors that you can use, and none of these approaches are exactly the same. And for the most part, people in their studies included all different types of lymphomas. At the NCI, Jim Kokendorfer, he published a really nice paper looking at CAR T cell therapy in diffuse large B cell lymphoma. And the numbers were small. There were about 12 or 13 patients, but there were 2 patients who had a very long remission of, they were actually 2 patients with primary mediastinal B cell lymphoma, and they had multiple lines of therapy before. And after they got CAR T cell treatment, they had a very good response. And at 3 or 4 years, when he published his paper, they were both still in CR. So I think over the next few years, we'll appreciate a lot more, where the sort of niche is for CAR T cell treatment, and which types of patients we should be really thinking about it in the upfront setting. And yeah.
Thank you, Kieron.
Okay, great. Thank you. Thanks. Yeah.
Okay, so an announcement is that I've lined up now the tumor board and the core facilities. So I'll be sending you all an email later this week. And if you want to visit these extracurricular sites, you can sign up for them, return the email to me by September 30th. We'll start doing the rotations in October. So our next speaker is Tina Annunziata. She's a graduate of Georgetown University Medical School. She came to the NCI Medical Oncology branch and started training with Lou Stout on NF-kappa B signaling and multiple myeloma. He's won many awards for this work, and she's now moved on to ovarian cancer. She's with the Women's Malignancies branch. The title, Ovarian Cancer in the Genomics Era. Tina.
Back on? Okay, great. All right. Thank you for inviting me to talk. I'm just going to give an overview of ovarian cancer and the genomics era to try to put this together, because a lot of work has been done over the past sort of 5 years or so. How do I do this? So what is genomics? So cancer genomics, as an overview, I would say a study of the genome and not study of individual genetic events. Study of chromosomes and study of gene expression, but on the global level instead of individual events, as I mentioned. So when did the genomics era start? I mean, really, the genomics era probably started in 1959 when Noel and Hungerford used the study of chromosomes to identify a recurrent abnormality in chronic myelogenous leukemia. They called it the Philadelphia chromosome because that's where they were. And it was, as I mentioned, in chronic leukemia. So what they did was they looked at a number of cases of chronic myelogenous leukemia and noted that most of them had this abnormal chromosome, as you can see by this arrow here, this abnormal chromosome. And they saw that that was a recurrent thing in patients with this cancer. It wasn't until 1973 that Janet Rowley actually published that this was a recurrent fusion between chromosome 9 and chromosome 22. And then in 1984, Groffin et al. Actually sequenced it and found that it was a fusion between the BCR gene and the breakpoint cluster region and the ABL kinase. And then in 1996, finally, we came up with a drug that blocked the ABL kinase and blocked and actually could be used for treating CML. And then eventually this drug became approved as imatinib. So that was a long period of time between the initial finding in 1959 and the approval of the drug in 1996. That was originally, I would say, was based on more of an observation rather than a functional experiment. So what is a functional genomic? So how can we get more functional? How can you find out what part of the genome is functional and actually what causes an effect? So what is actually driving the cancer? Looking for things that transform normal cells into cancer as driver alterations. So another type of approach, in 1981, she et al. Discovered the gene HER2/neu, which actually they called neu to begin with because it was from carcinomas and neuroblastomas that they actually took the DNA on a global, all the DNA, chopped it up and introduced it into mouse fibroblasts that were benign, and then saw which of these genes would transform the fibroblasts that could grow in vitro and then grow in mice. So they actually called it neu, and it wasn't until later on, actually in 1984, that Schechter et al. Found that neu was actually related to the epidermal growth factor receptor. So they found this by a southern blot looking at these ERB-B, which they called it ERB-B related sequences. And then in 1985, Cousins et al. Found that this gene, now that they were calling HER2, was found on chromosome 17. And so you could see in these cases of these individual chromosome 17 from various cancers, there's an amplification of chromosome 17 here, which is recurrent. And that is associated with the HER2 amplification. And then in 1987, Dennis Slayman et al. Found that actually this amplification was recurrent in certain types of breast cancer. So now we have affiliated this with a disease. Now, if you remember, at the beginning, they actually used neuroblastoma. So it's not really specific for breast cancer. However, it is most common that we use today in breast cancer, the HER2. So, and then I didn't put the slide in here, but eventually the HER2 targeted therapy, Herceptin or trastuzumab, was the first monoclonal antibody approved for the treatment of breast cancer with the HER2 amplification. So this is actually a targeted therapy, but based on a functional approach that discovered it, not just random sequencing and observational studies, but a functional approach. And I'm going to come back to this later on. So what about ovarian cancer? Do we have any drivers? Have we done any functional experiments, and do we have any drivers in ovarian cancer? So just to back up and give you a little background on ovarian cancer, it's the most lethal gynecologic malignancy in the United States, resulting in greater than 16,000 deaths per year. Is the 5th most common cause of cancer death in women. And this is because 70% of ovarian cancers are diagnosed at advanced stage, and less than 35% of those with advanced stage will be alive at 5 years. And this is sort of emphasizing that point, is that the incidence of stage 1 and 2 ovarian cancer is 25%, where the survival is almost, well, 65 to 90%, whereas stage 3 and 4 is the majority, probably 75% is diagnosed in stage 3 and 4, but the cure rate is less than half, or so probably around 40 or less %. So what is the treatment for newly diagnosed ovarian cancer? First, complete surgical staging, followed by optimal cytoreductive surgery, which means less than 1 centimeter of disease left, followed by chemotherapy and clinical trials. So chemotherapy, just to highlight, is platinum and taxane, and this is based on many years of cooperative group studies that have compared various regimens. The standard of care is cisplatin or carboplatin in combination with either paclitaxel or docetaxel, most commonly being carboplatin and paclitaxel. And then I have highlighted here intraperitoneal if stage 3 with an optimal reduction. And that is based on this timeline, where you could see here in 1960s, when we only had alkylator chemotherapy, there was nobody who lived with advanced stage ovarian cancer, meaning 3 or 4, that lived for 5 years. 1970s, we had the introduction of platinum single agent, which led to a small benefit in 5% of patients that were alive at 5 years. Combination therapy was brought into the clinic in the 80s with a 15% response, 15% 5-year overall survival. And then in the 90s, we had the introduction of taxanes, and the taxanes actually were giving us even more of an increment in survival, 35% of patients alive 5 years or more. And then in the 2000s, we had the introduction of not a new chemotherapy, but a new administration of the chemotherapy, bringing the overall the 5-year survival up to 40% in the 2000s. So what do we know about ovarian cancer? So we treat ovarian cancer as one disease, as you saw from that sort of timeline of chemotherapies. Ovarian cancer occurs in the peritoneum, which is why the peritoneal therapy is recommended as standard of care. However, ovarian cancer is not one disease. As you can see here, even histologically, you can see there's 5 different subtypes of ovarian cancer: serous, endometrioid, clear cell, mucinous, and other types, and a sort of undifferentiated cancer. So based on this, you would say it looks really different. It must be a different, it's a different cell type for sure. But why? But we still treat it all the same based on its location in the body. We don't even really know for sure the tissue of origin, and I'm going to go into this a little bit detailed. But we're not even sure of the tissue of origin in the gynecologic tract for each different subtype of ovarian cancer. Probably the thoughts nowadays is that fallopian tube is probably the origin of serous type histology, whereas endometriosis might be the etiology for endometrioid and clear cell subtypes. But again, not a clear differentiation between those two. Overall, it does come from some part of the Mullerian epithelium that occurs in an extrauterine site. But again, very unclear really, where is the tissue of origin. So many studies have been undertaken at a genomic level for ovarian cancer in the hopes that increasing our understanding about the biological and biochemical events underlying progression of ovarian cancer will create new avenues for treatment. So what do we know? I'm going to give a brief overview touching on each of these. I have references in the bottom if you want to look into them even more. This is a brief history of genomics in ovarian cancer to date. Clear cell cancers, 5 to 10% of all cases. Now this is much less common than serous histology, which is 70%, and I will talk about that in a bit. Clear cell cancers tend to have a worse response to standard chemotherapy, which was based on the serous cancers, which is the predominant cancer. Clear cell cancers, as I mentioned, in up to 40% of situations can be found associated with endometriosis in the peritoneal cavity. So in 2010, a paper published in New England Journal of Medicine sequenced RNA from 18 clear cell ovarian cancers and 1 cell line in a discovery phase. And then they sequenced DNA exons from an additional 210 samples, including 101 more clear cells, 33 endometrioid, 76 serous, and 1 more clear cell line for validation. And they went on to immunostain their predominant findings in 455 additional samples. So really a large effort with the number of cases involved here. And what they found was that there were recurrent aberrations, whether they were mutations, insertions, deletions, missense, nonsense, mutations in the ARID1A gene. So what is ARID1A? ARID1A is a chromatin remodeling gene, a chromatin remodeling protein involved as a part of the SWI/SNF remodeling complex. And it has been previously found to be mutated in breast cancer and lung cancer. It's found on 1p36 and is actually deleted in 6% of all cancers. So when you see things that are deleted, have nonsense mutations, these are potentially tumor suppressor genes. So basically you're losing its function in the cancer. In fact, they did find that in cases where ARID1 mutation occurred, there was loss of ARID1A protein expression. So this is showing you in the protein expression of the BAF250A protein, which is the protein product of the ARID1A gene. And in cases that had an ARID1A, this is a little bit confusing, 70% had loss. So going up is actually more loss. 70% had loss of the gene in clear cell and 50% in endometrioid, whereas if they did not have an ARID1A mutation, there were much fewer that had loss of the gene. But here you note that it is highly specific to clear cell and endometrioid types, histologies, and there was none found in any of the high-grade serous cancers that they looked at. So very nice isolation of this gene specific to endometrioid and clear cell cancers. Over 40% of clear cells, 30% of endometrioid, but less than 1% of serous. However, it was not found by a functional test, right? So what did they look at? They looked at just shotgun sequencing of a lot of cases, but there was no sort of drive to find out if it is actually functional. We don't know its oncogenic mechanism. We don't have any indication of which resulting pathways are affected, and so there's unclear therapeutic utility in this case. Of course, there's diagnostic utility, but unclear therapeutic utility as of yet. I mean, that's not to say that tumor suppressors have not been targeted, and we have done some successful targeting, which I'll talk about in a little bit, but in this case, not a functional test and not a functional outcome. That's what I just said. Okay, mucinous cancers. What about mucinous cancers? Well, we know since 2004 that, well, we know before that, but this is showing you mucinous cancers have worse overall survival than regular non-mucinous cancers. Significantly worse. So in 2006, actually this came out of the NCI, they looked at gene expression profiling, so global gene expression of normal, this OSE is ovarian surface epithelium, so this is non-transformed, normal patient samples, serous of low-grade malignant potential, so serous cancers that are sort of grade 1, serous grade 3, so high-grade serous cancers, mucinous low-grade, higher grade, and mucinous low-grade. So mucinous cancers, you can see right here, very much grouped together, showing that they had a distinct genetic profile, gene expression profile, than the serous cancers. And of course, the serous cancers grouped together, and the mucinous cancers all grouped together. So showing that actually, yes, on a genomic level, mucinous cancers have a different pattern than serous cancers. Very small study here showed that mucinous cancers tend to have KRAS mutations, similar to low-grade serous, which also have been shown to have KRAS mutations. Very small studies, 15 of 22 low-grade serous cancers, 31 of 51 precursor lesions, but none of the high-grade cancers had KRAS mutations. So is this a potential target? This was not really a genomic level, but this is sort of a single gene genetic level. Here's just summarizing that the serous borderline, so low-grade serous, none of high-grade serous, and maybe a few of endometrial clear cell have BRAF and KRAS mutation. So at least KRAS is potentially a driver because it actually does something. Can we target it in ovarian cancer, low-grade serous? So here you see, the pathway. So RAS is here, signaling downstream of the receptor and signaling down to ERK through MEK. So what people have tried is actually a MEK inhibitor. So there was a study of 52 patients with recurrent low-grade serous ovarian cancer that did a study that received a MEK inhibitor. So they're trying to block this specific downstream pathway of the RAS mutation. They had 52 patients and 8 patients responded. 34 had stable disease greater than 4 months, which is actually not that surprising for low-grade cancer. So here we see, okay, well, yay, we had 8 patients. Let's see if those are the patients that had the KRAS mutation. Can we correlate KRAS mutation to response to the MEK inhibitor? And the answer is actually no, because here you see that 5 of the 18 patients that did not have a KRAS mutation actually responded, whereas only 2 of the patients with a KRAS or BRAF mutation responded. So it didn't quite correlate there. So what happened? Well, we all know that KRAS signals through many pathways. We were focusing on this pathway, but probably there's a lot of other pathways that feedback. So we never had evidence beforehand that MEK inhibitors would actually work, and they didn't. So there you go. What about high-grade serous cancer? So this is where we focus mostly on in our clinic, and I'm going to show you some results of our trials. But let's go back to what about the genomic analysis of high-grade serous cancers. So high-grade serous cancers, as I mentioned, are the most common, 70% of ovarian cancers. Cancer Genome Atlas focused on this for that reason. Clinically annotated high-grade serous ovarian cancers. The goal was to identify molecular abnormalities that influence pathophysiology, affect outcome, and constitute therapeutic targets. What they did was microarray analysis, 489 cases where they looked at mRNA expression, microRNA expression, DNA copy number, DNA promoter methylation, and whole exome sequencing in 316 samples. So, functional experiment? No, it is not a functional experiment. Again, we are broadly looking at shotgun sequencing expression and not at functional mutations. So, what they included, newly diagnosed patients, ovarian serous adenocarcinoma, no prior treatment, and they had to have a companion normal tissue specimen, which could be adjacent normal tissue, peripheral lymphocytes, or previously extracted germline DNA. What they found, probably you guys are all aware of this already, but I'll just summarize quickly. This is just from the original population where they really don't have that much other to look at besides glioblastoma. But you can see here, this is the copy number analysis, and these are the high-grade serous cases, and this is the glioblastoma cases, and these are the chromosomes on the vertical axis. Blue is deletion, red is amplification. So you see in glioblastoma, kind of quiet here, not really much going on. A lot of amplification, recurrent across all the cases. And then a lot of deletions here, recurrent across all of the cases. But what do you see in ovarian cancer? Is a complete mess across the whole genome. So you see losses, gains everywhere. Every single chromosome is involved. You have some sort of abnormality across there. So what does that mean? Actually, that is quite interesting because that has led to thoughts about, is it a recurrent genetic abnormality in high-grade serous ovarian cancer, or is it just the fact that there is this global disarray, and can we use that as a target? Significantly mutated genes, not that many. You can see here kind of a defining feature of high-grade serous ovarian cancer is the P53 mutation, which has been known, and that was sort of verified here, whereas pretty much nearly all of the patients had either a mutation or a loss of P53. The other recurrent abnormality, again, we knew this, BRCA1 and 2. BRCA1 and 2 are breast cancer-related genes, but they also lead to the breast and ovarian cancer syndrome. So breast and ovarian cancers can occur in women with this hereditary mutation, occurs quite frequently in Mediterranean populations, especially Ashkenazi Jewish. So interestingly, there were homologous, so BRCA, I'm going to go into a little bit, but BRCA is a member of the homologous recombination DNA repair pathway. So if you remember, homologous recombination is the most reliable way to fix double-strand DNA breaks. Other recombination pathways, other DNA repair pathways generally focus on single-strand breaks, which we'll get to, which is how we can target. So interestingly, homologous recombination alterations occurred in up to 33% of cases, either with a BRCA1 mutation, a BRCA2 mutation, or methylation of the gene. And then this is also downregulation of gene expression. Sorry, that was in this one. Germline mutation, somatic mutation, and then epigenetic silencing. So what they looked at here is that actually the BRCA mutated cases had a better overall survival, so better response to standard chemotherapy with platinum and taxane. Interesting, because platinum is a very strong DNA damaging agent. So so they respond very well, more well to platinum, whereas the BRCA epigenetically silenced and the BRCA wild type actually had a worse prognosis. So one of the summaries from this paper, from the original Genome Atlas publication, was that there were many altered pathways in ovarian cancer. Some of the predominant ones focused on DNA repair and cell cycle progression. So what next? So what do we do with all this information? Are there new therapeutic approaches? Well, we have 50% with homologous recombination defects, which I'll show you, and we potentially could treat those with a class of drugs called PARP inhibitors, which I will talk about. There were also some other commonly deregulated pathways, such as the RB pathway, the PI3 kinase pathway, FOXM1, and Notch signaling, possibly. And then the quote from this paper is that inhibitors exist for 22 genes in regions of recurrent amplification. And those trials are all ongoing. But again, as I mentioned, perhaps it's not individual genes that we should focus on, but they're actually networks and pathways that need to be targeted in order to get a selective therapy. And we sort of learned that from the KRAS story, in that we can't just target one part of it, because probably there's going to be feedback that the cells can recover their signaling from. So we need to target a network rather than an individual gene in ovarian cancer. Okay, so targeting homologous recombination pathway. And this is where we've had some success with PARP inhibitors. Now, the BRCA mutation, as you all know, was not discovered in the Cancer Genome Atlas for ovarian cancer. It was discovered in 1987, actually published in 1990 by Mary Claire King. And that was found by sort of a functional approach, looking at what was similar, what was happening in these women who had families, families of multiple generations of cancer. And she was mainly focused on breast cancer, but again, ovarian cancer is also in this syndrome. And you can see here in this family was ovarian, and then breast. Okay. So, as I mentioned, in the Cancer Genome Atlas, they found BRCA1 germline and BRCA2 germline, but they also found BRCA1 and 2 somatic mutations, also found methylation, although that was not very well associated with survival, but then also found other proteins involved in homologous recombination that could potentially lead to a defect in homologous recombination. So almost 50% of cases in Cancer Genome Atlas in the high-grade serous cancers had potentially a defect in homologous recombination. Now, it's possible that that defect is what's leading to this vast chromosomal instability and chromosomal aberrations. So this all sort of makes sense in a way from a molecular pathway standpoint. So people, many groups have been interested in, since then in homologous recombination. This is just one example showing that in cell lines, people can come up with a signature of homologous recombination deficiency. And they did this by looking at cell lines with a BRCA, or cell lines and patients with BRCA1 deficiency, a BRIT1 deficiency, and a RAD51, and then came up with this little signature of 230 genes. And when they look at this signature in patient samples, this is breast cancer, that patients with a defect in homologous recombination actually do better. Again, similar to the ovarian cancer story, than patients with intact homologous recombination. And then here's where the PARP inhibitors come in. When you treat the cell lines with a PARP inhibitor, the ones with deficient homologous recombination actually respond with a lower IC50 than the ones with intact homologous recombination. So what is a PARP inhibitor and why do we care about it? So in BRCA mutant cancers, so you have in your typical cell, you have your DNA and it is damaged by multiple causes. So it can be damaged by cellular metabolism, environmental exposures, sunlight, you can get single strand breaks in DNA. That's a common phenomenon. And what happens is that PARP, in one of the base excision repair pathways, which is a single strand break repair, the PARP enzyme comes in, marks that area for polyadenylation. So PARP stands for poly-ADP ribose polymerase. So it gets poly-ADP ribose chains and then marks that for area, and you get assembly of the DNA repair complex. But if you have a PARP inhibitor, single strand break does not occur. In replicating cells, as you know, the replication process causes a nick in the DNA to unwind it, so that single strand break gets converted to a double strand break. So now you have a double strand break. In a normal cell, of course, you can repair this by homologous recombination. And then the cell can go on to have a normal replication. If you have a cancer with a BRCA deficiency, the homologous recombination pathway is defective, and the cells have a very slower pathway of repairing double-strand breaks. Most of the time, that does not suffice when you have a lot of damage, and so you get cell death. So this is the idea behind the development of PARP inhibitors. Olaparib is the first approved PARP inhibitor, and in fact, it is approved for the treatment of women with BRCA-associated, BRCA mutant ovarian cancers. It is orally active, it's not novel anymore, but this is the old slide, is orally active PARP inhibitor, and it had been shown to have synthetic lethality in cell lines with BRCA1 or BRCA2 homologous deletion, homozygous deletion, compared to wild-type cells. So we ran a phase 1b study of olaparib in combination with carboplatin. So I mentioned that carboplatin is something that causes a lot of DNA strand breaks, mostly single strand breaks. And so we thought we would augment the single strand break with the olaparib, blocking the single strand break repair, and be able to have good responses in recurrent ovarian cancer. So we had 3 cohorts on this study. The first cohort was anyone with a BRCA mutation with breast or ovarian cancer. Or they could have a high likelihood of having this BRCA mutation without having been tested, which means the BRCA pro greater than 30%. So if they have a strong family history, basically. We had another cohort with triple negative breast cancer here. And we had a third cohort with high-grade serous ovarian cancer that were known to have a normal BRCA. And these are all, actually, these are both in press now. This one was published already. And the other 2 are clinical cancer research. So this cohort, actually, we were able to dose escalate olaparib 400 milligrams twice daily and carboplatin with an AUC of 5 every 21 days. We did have to give them a 2-week break because otherwise the blood counts would not return to normal. This cohort actually only dose escalated to an AUC of 4, probably because they had more prior therapies, and the same with this one because they probably had more prior therapies and just a lot of regimens beforehand. So in the BRCA mutation cohort, we had 45 patients. 37 had ovarian cancer and 8 had breast cancer. We had 30 patients in the dose escalation and 15 in the 1B expansion. As I mentioned, the carboplatin was AUC 5 on day 1, and olaparib was 400 milligrams twice daily on days 1 through 7 every 21 days. These are the dose levels that patients were in. So dose level 6 is the one that most patients were in because that was the expansion cohort. But even on the lower dose levels, this is the response curve. So we had patients with a 30% response would be considered a response. We had stable disease or responses in pretty much all of the patients with the BRCA mutation. So this is actually quite remarkable. So these were heavily pretreated patients that had had multiple therapies, were resistant, for the most part, resistant or refractory to platinum agents. And we gave them the platinum plus the PARP inhibitor, and we got at least stable disease, if not almost complete responses in some of the patients. And actually, interestingly, we have the 3 patients with the response still on study after 5 years. So this is actually very remarkable. And this is breast and ovarian cancer, as I mentioned. So that was highly successful. This is just a summary. We had no complete responses at the time of this publication, but since then we've had 3 patients with a complete response that have gone on to a complete response. Partial response and stable disease in nearly all of the patients. 6 of them did have progression with an overall response rate of 44%, clinical benefit rate of 82%. So that was great, and that is based on genetic analysis. So our conclusion from that study was that olaparib is well tolerated in combination with carboplatin. So that was one worry, is that people with BRCA mutation are actually going to be more susceptible to having side effects with low blood counts because their bone marrow cells, their normal cells, really just have one good copy of BRCA. But that was not the case, actually. It was well tolerated, and even we could give it up to AUC 5, which is a standard dose of carboplatin in the non-BRCA mutated community. Highly, highly active in advanced chemotherapy refractive BRCA deficient cancers. Greater activity, of course, at the higher dose. But this is positive proof of concept that the activity and the tolerability of genetically defined targeted therapy with olaparib in BRCA deficient cancers. So this was a great result. But again, that was not a functional experiment, and so we were lucky enough to have the drug that was targeted towards the homologous recombination pathway that was figured out before we actually started the study. But what can we do about a functional approach? How can we sort of more efficiently identify targets for ovarian cancer? So the common thing nowadays is to do these sequencing for actionable mutations. But what does that actually mean? There are a number of commercially available tests, such as Caris or Foundation One, and they give you back these long reports. We've sequenced all these genes. These are possible benefit, and these are unlikely benefit. That is how a physician will get the report. So should we use this drug? Maybe we shouldn't use that drug. It's a little bit unclear. Basket clinical trials, such as the NCI Impact trial, are looking at sequencing individual genes and putting patients in baskets for various drugs based on their mutation. So for example, if they had a KRAS mutation, they might go to the MEK inhibitor. If they had a PI3 kinase inhibitor mutation, they might go in the AKT inhibitor study or others. So they're assigning treatment based on a mutation. But typically, there's no functional link. This is, again, sequencing. We're looking for things that have been found in other cancers, but we don't know if it's going to be functional in your particular cancer. And interesting, there was a very well-written, I think, article in Journal of Clinical Oncology by Reddig and Yanni in 2015. And they said that the word actionable depends in large part on the strength of the data linking the target to the targeted therapy. And that's where I think we don't have a lot of functional data. For this trial design to work, two key conditions must be met. The tumor must depend on the target pathway, and the targeted therapy must reliably inhibit the target. And they said achieving both goals can be a matter of some complexity, which is somewhat of an understatement. Okay, so I still think that we need a functional experiment. So what can we do with functional genomics? So what we have is a shRNA retroviral library. And in this paper, actually this paper was looking at this library in lymphoma, but we went ahead and used it in ovarian cancer. So this library has shRNAs targeting 2,500 genes with at least 3, probably 6 to 12 shRNA constructs per gene. 10,000, there are 10,000 constructs in the library. They're all sequence verified. They contain a 60-mer barcode sequence, so you actually don't need to do individual, like an SI plate. You wouldn't do individual 96 well or 1584 well plates. You actually just do a pool because they're all individually barcoded. The library targets all protein kinases, PI3 kinases, deubiquitinating enzymes, NF-kappa B pathway regulators, and then differentially expressed genes in lymphoma, because that's where the library was developed. But it does look at tumor suppressors, apoptosis regulators, and oncogenes. So the experiment is this. The experiment is you would infect the shRNA library in pools into your cells of interest. So you have your little shRNA and your barcode. You infect it into your cancer cells. And in some cases, we have the shRNA in an inducible construct, and we can induce it for 21 days or not. And then we look for genes that dropped out. Some cases, we have library or no, or library or control in the cases where it's not inducible. But in this case, we have an inducible situation. We're looking for barcodes that drop out of the induced but are present in the non-induced, and then used to be a barcode microarray, but now we just sequence the barcodes because that's more in vogue. Okay, so what we did, we put this library into 4 different ovarian cancer cell lines. We used 2 serous cell lines and 2 non-serous cell lines. And what we found was we looked for the genes that were overlapping in 3 out of the 4 cell lines. So we found that 63 shRNAs representing 55 genes were common to at least 3 of the 4 cell lines. So what are these genes? These are the whole mix of them. There are many. And we did follow up on these in a sort of validation screen in the individual siRNA with 2 siRNAs per gene. So we did have a functional experiment. We're actually looking at cell lines for things that when you knock them out, does it block cell growth? We did follow up in 6 additional cell lines, like I said, with the individual siRNA plates, so we could follow up on those 55 genes with 2 different RNAi constructs, and we focused more on druggable targets for drugs that actually already existed. We also looked at specific subgroups, whether it was serous versus non-serous, et cetera. We prioritized this particular gene, CHEK1, because we found that it was one of our very, very top hits in all 4 of the cell lines. and it was actually overexpressed in nearly all of the ovarian cancers in the Cancer Genome Atlas. So CHEK1, the CHEK is involved, as you would imagine, actually, in the DNA damage response. So DNA damage occurs, and CHEK1 actually signals downstream of ATM, which is ataxia-telangiectasia mutated gene involved in DNA repair. It actually signals to arrest the cell cycle in G2M until it can be repaired. So that kind of makes sense, because if ovarian cancer is having a ton of DNA damage and is susceptible to that, it would need to upregulate this gene in order to stop their cell cycle so that they can repair their DNA. Just briefly, one figure from our paper, we found that actually the high-grade serous lines were much more susceptible, had a lower IC50 than the non-high-grade serous lines. Multiple other experiments, and eventually ended up with a clinical trial that is currently ongoing. Actually, we are showing a remarkable response rate, and I just had another patient in clinic today that had a confirmed response, almost complete eradication of her cancer. Again, highly pretreated, many prior therapies, refractory to platinum, but is responding to this CHEK inhibitor in the high-grade serous cases. Highlighted by a functional genomics approach. So, to summarize, I went a little bit fast. Ovarian cancer genomics has revealed that there are multiple areas of potential targeting that are specific to various cell types in ovarian cancer. As I mentioned, the ARID1A in clear cell and endometrioid, KRAS in low-grade serous mucinous, and then the homologous recombination is the big one, not a single gene, but a pathway in high-grade serous cancers. So as I mentioned, in 1981, a functional approach discovered HER2. In 2000 and whatever, 2010, I guess, whenever we started the experiment, 2016, a functional shRNA library screen found CHEK1 in ovarian cancer. So if we can do a functional genomic screen, identify a driver, aberration, or a pathway, lead to a clinical trial, ultimately improve therapy for ovarian cancer. And with that, these are the women's cancer team. These are the translational scientists. These are the collaborators for the shRNA library. And of course, funding is from the National Cancer Institute. I will take any questions. Yes?
High-grade serous cancers, are there any diagnostic biomarkers or any opportunity for patients to identify that they might be present with the disease before it's happening?
Oh, okay, so a serum biomarker. So the CA-125 is a marker. It's not approved FDA for diagnosis. It's approved for monitoring recurrent disease. The CA-125 marker actually is very interesting. We just had a very, very large study finished for using that for screening. It's not very effective, and the reason why I think it's not effective is because it's looking for serous cancers. It's not looking for all cancers. So we're looking for a marker to identify all ovarian cancers, and we're using a marker for serous cancer. So that, in my opinion, that's why it does not work as a marker. If we were looking for a marker, I think it would have to be specific. You would have to be looking for specific cancers. And I think those studies should be ongoing. Right now, they are not, as far as I know. Another opportunity, I think, would be looking for circulating tumor DNA if we knew a recurrent mutation like the ARID1A. Those are not ongoing as far as I know. But it is a dilemma. It's a very big dilemma because, I mean, right now the symptoms are really just kind of GI symptoms, gastrointestinal. They're very nonspecific. And that's why people don't sort of report, you know, nobody has like hemoptysis, you know, nobody's coughing up blood, nobody has a lump in their breast kind of thing. It's very difficult. But I do think we need novel approaches, maybe circulating DNA, maybe more specific looking at different cancers.
So how many subtypes of ovarian cancer do you think there are?
Oh my goodness. Well, I mean, we're getting to I think all cancers now are getting to a very personalized level. So even like all triple negative breast cancer is not the same, right? So everybody's subgrouping. So, I mean, in some sense, you have to lump in some sense because you have to say like who should get this therapy. So maybe people with a check amplification should get a check inhibitor. But there are certainly like subtypes within high-grade serous. Certainly there are at least like the 5 histologic subtypes. Within high-grade serous, I think there is at least another few subgroups because we can't treat all high-grade serous. You know, everybody doesn't respond to the same therapy. So we're not getting 100% response rate, and until we get 100% response rate, then I think we can't really say we're treating them all the same. Yes. I'm sorry, I didn't understand the question. Can you? Are there other what? Oh yes, yes. I think there's there's a lot of promising research going on, definitely. So in the clear cell cancers, what I didn't mention is that they have a very vascular. They're very vascular, and so all the angiogenesis inhibitors actually are looking promising for the clear cell cancers. For example, so sorafenib, sunitinib, bevacizumab. Those are looking promising for the clear cell cancers. And then, I mean, people are definitely looking at the PI3 kinase pathway for the endometrioid cancers. So yeah, so I mean, there are many avenues that I didn't talk about. Yeah. The BRCA1 and 2. I mean, the hot topic is the PARP inhibitors and looking at the homologous recombination. A lot is going on with respect to looking at, see if we can find other people that have a BRCA-like, so homologous recombination defect, that might also respond to PARP inhibitors, because there were some patients in the early studies that didn't have a PARP inhibitor, that didn't have a BRCA mutation that did respond. So that's kind of the hot topic there. And then, what else was I going to say? Sorry, I lost my train of thought. I don't know what it is. So within the BRCA field, I mean, I think that is certainly the area to focus on. Okay. All right, thank you.